what I'm going to do is talk about the generalized retinal degenerations, because of course for time limitations I cannot talk about the macular degenerations right now. And then we will review them together, see some phenotypic features together, see how we can diagnose them, and then see what is our role nowadays as ophthalmologists when we are faced with somebody with an inherited retinal degeneration. Because in the past we used to say, well, I'm sorry, there's not much we can do, but now this is no longer acceptable. Now we really have to push ourselves and get to a very clear diagnosis and go from there and help the patients in all our ways. So what are inherited retinal degenerations? Well, these are heterogeneous group of blinding conditions that affect the viability of the photoreceptors and the RPE cells, and they affect approximately 1,000 to 2,000 individuals. And of course, as we all know, they cause a significant loss of vision and have been thus far, except for one exception, incurable. Okay. Now we have nevertheless have had in the past 30 years lots of advances in terms of understanding the genetics and understanding the pathogenesis, and this of course led to clinical trials and to the development of some very exciting treatments such as gene replacement and cell transplantation. Now, as we all know, vision is mediated by the retina, and the macula is responsible for central vision, color vision, acuity, recognizing faces, reading, and so forth. And the peripheral retina is responsible for vision in the periphery, our field, and vision in dim light. And the retina is made primarily of a network of cells, but the first receptors are the photoreceptors, which are very light sensitive. They absorb and they convert the light through a mechanism or a process called the phototransduction cascade into a photochemical and then an electric impulse that sends the impulses towards the bipolar cells, the ganglion cells, and then to the brain. And there are approximately 120 million rods which control the vision in dim light and peripheral vision, and a much, much smaller number of cones, 7 million of cones that control the daytime vision and acuity and color vision. And although they are very concentrated in the macula, the biggest proportion and the biggest number of the cone population is actually outside the macula. And this is important to re-emphasize again here, is that when you have a macular disease that affects only the macula, of course it will affect the cones in the macula, and you will have, or the patient will have, a very decreased visual acuity. But if you do a full field ERG that tests the cones, the cone ERG is going to be normal, because the majority of the cones are outside that area of insult. But however, when you have a cone dystrophy, this will very well show itself on a full field ERG. Besides the photoreceptors, the RPE is a vital cell that supports and nourishes the photoreceptors and has a lot of functions. But one of the very important functions is that it mediates the continuous process of recycling of the retinoids that are stacked in the photoreceptor discs by something that we call the retinoid cycle or the visual cycle. Let's look at this together. Just to reiterate, you have 11-cis retinal, which is usually complexed with opsins, rhodopsin in the rods. When this chemical is basically hit by light, it is converted immediately into an all-trans retinal state. As you can see here, the ABCA4 gene, which is a major gene that most of you know in Stargardt and cone dystrophies, plays an important role here in this conversion. And then you have the RDH gene that converts it into an all-trans retinol. This is transported then to the RPE, here depicted in orange, the RPE cell, and where the LRAT enzyme, gene that controls the enzyme, is going to convert this into an all-trans retinal ester. And then comes into play the RPE65 gene, which controls the enzymatic process that makes this again into an 11-cis retinol and then an 11-cis retinol. And then this is taken back into the photoreceptors. This is the visual cycle. And it's very important that, enough 11-cis retinol is replenished so that vision can occur. Now, inherited retinal degenerations are, of course, caused by mutated genes that produce dominant or recessive diseases. And each pair of gene dictates one trait. And a mutation, which is a change in the gene, is going to alter the instructions of that gene, causing an abnormal trait or disease. And depending on the inheritance, it could be an autosomal dominant inheritance, recessive inheritance, or X-linked inheritance. Now, those genes that are identified in the inherited retinal degenerations are going to affect the retina by a variety of molecular pathways, either occurring in the retinal pigment epithelium or in the photoreceptors. Now, you can see, and this is just to mention a few, but very important to know that in the RPE, the visual or the retinoid cycle is very important, and there are genes that control that. And in the photoreceptors, we need to know these processes, and particularly the ones that affect phototransduction and ciliary transport. Now, the retinoid cycle, here it is. This is an RPE cell. This is the photoreceptor. This is the outer segment with its stacked membranes, the cilium that connects the photoreceptor outer segment to the inner segment, and then the nucleus and the axon. Now, again, what controls the visual cycle are these major genes such as the RPE65, which you've heard a lot about, which is a key enzyme that encodes the retinoid isomerase. And if it's mutated, then the patient cannot generate the 11-cis retinal, and the photoreceptor will eventually, the patient cannot see, and the photoreceptor eventually dies. LRAT, again, is an important gene, and RDH12 is another very important gene. In the phototransduction cascades, this is the enzymatic process, by which the light transforms and causes, ion channel depolarization in the photoreceptors, and transmission of electricity into the bipolar cells and ganglion cells and so forth. These are the genes that are very important, and you need to know. Well, photoreceptor structure genes which control the morphogenesis and the internal cell structure, such as CRB1, very, very important gene, and the peripherin gene, which is also a very important gene. This is a very important group of genes which control the ciliary transport, okay? And these are going to control the transport of stuff between the photoreceptor outer segment and inner segment, and they cause ciliopathies, okay? So they are located in the cilium, but those genes can also be responsible for altered mechanisms in other cilia of the body, such as in the inner ear, in the kidney, and so forth. So they're a very important group of genes that can cause just retinitis pigmentosa, but also syndromic inherited retinal degenerations. Now, there are genes that affect the photoreceptor channels. A very important one is the KCNV2, and the transcription factors, which essential for the phototransduction cascade, and there are metabolic enzymes and so forth, and many of them. We cannot go through all of them, nor is this very important. But what you need to know is that the classification of the inherited retinal degenerations is kind of complex and could be actually confusing because there is a significant genetic overlap. Of course, we can classify the entities into autosomal dominant, recessive, and so forth. We can classify them on whether they basically affect mostly rods or affect mostly cones, depending on the symptomatology, depending on the ERG. We can also classify them whether they're generalized or whether they're just located to the macula. If they're progressive or stationary, and with this you will going to need time or at least a family history. You can classify them according to the age of onset, call something Leber, and congenital amaurosis, call another an early onset RP, and so forth, or a juvenile RP. You can do all these things, and you can also classify them whether they're isolated or syndromic. But if you look at this chart and here, you will find there's a lot of overlap. For instance, a Leber congenital amaurosis, which is the blindness that occurs since birth, since the first weeks of life. What happens is it can be by itself. Either you can even have cases that have primarily a rod involvement, and those that have primarily a cone involvement. And if you wait long enough, with time, the ones that have a rod involvement can actually become retinitis pigmentosa with time. And the ones that are mostly cone, where they have a cone involvement, or even cases of cone dystrophy, those with time can end up having a cone rod dystrophy. Similarly, retinitis pigmentosa with time is the rod sickness is going to affect the cones, and the cones are eventually going to die. So there's a lot of overlap, and the clear distinction is often not very, very possible. The other thing is that the mutations in more than one gene can result in a single clinical phenotype. Let's say, for instance, you have retinitis pigmentosa. Here is a number of genes that can give retinitis pigmentosa. Okay, they all give retinitis pigmentosa. They can look very, very similar. And also, you can have a single gene mutation that can give different phenotypes. For instance, ABCA4 can give Stargardt disease, can give a phenotype of a rod cone dystrophy or a cone rod dystrophy, and so forth. So there's a significant overlap, and if you want to get even more confused, here it is. You've got some of the genes that affect the retinal degenerations. Let's look at the retinitis pigmentosa. Now, these genes, all of them give retinitis pigmentosa, but notice that some of them also give Leber congenital amaurosis. Some of them are going to give cone dystrophy or cone rod dystrophy. Some of them are going to, also give macular dystrophies. Usher syndrome, has some, overlap with RP. Bardet-Biedl syndrome has some overlap with RP. So it's a huge thing. So before I get too technical here, let's take a quiz among ourselves. I'm going to show you a few cases and see whether you can recognize some features. I told you that there's a lot of phenotypic variability, and one genotype can give a lot of phenotypes. But there are some phenotypes that are very suggestive. Let's say some are pathognomonic, but some are suggestive. And let's try to make this more interesting by showing you and by trying to find out whether you can recognize any of the suggestive ones. Here's a patient who has night blindness. Okay. Now notice the pattern of the pigmentation. Notice what I'm showing you here with the vessels. Okay. And notice that this is another patient. This patient has exudation. And notice the OCT. Okay. Don't say anything. Just think among yourself, can I make a genetic diagnosis based on what I'm seeing? Because this is pretty evocative. Now, this is a patient, a child, who has Leber congenital amaurosis, but the patient sees during the day, okay, night blindness, severe night blindness, and they're like, whitish drusen deposits. When you do an autofluorescence, no autofluorescence. What is possible? Think. This is another child. This is a child who also really behaves like a completely blind infant. But when there's light in the room, the child can't keep his eyes off the light. He likes to stare at light. Light staring. And if you do an autofluorescence, no autofluorescence. This is evocative. These are two different patients. And the first thing I'm going to ask you is to look at the fundus and look at the background in both. And think for a while, can this be retinitis pigmentosa, or is this something else? What is peculiar about this? What is peculiar about the fundus background? And are they the same? Is the fundus disturbance the same? Are they the same entity, yes or no? This is a patient who has a lot of clumping, pigment clumps along the arcades, and even in here. This patient, another patient with the same entity, has what looks like a retinoschisis in the center. And the ERG is pretty pathognomonic. This patient has night blindness, has hyperopia, and a very pathognomonic ERG. This is very, very pathognomonic. This is another patient, actually two patients. Two were seen here. One of them was actually treated for uveitis because of the presence of these whitish spots, the scarring of the subretinal fibrosis, and the presence of what looked like CME and maybe subretinal fluid. But this is very, very pathognomonic of another entity, that is a genetic entity. And finally, for your good eyes, this patient was also treated as uveitis because of the tremendous amount of scarring. But if you notice, there are other things happening here that do not look like chorioretinitis or choroidal, infarcts, not infarcts, but, granulomas, what have you. So this is something else. Okay, so let's look at the progressive generalized retinal dystrophies, and let's start with the isolated ones. We're going to talk about the most important ones. LCA, Leber congenital amaurosis, is by definition autosomal recessive. It affects approximately 20% of legally blind children, and by definition, it occurs since birth or since the very early weeks of life. And it's characterized by the combination of blindness. Okay, so basically the baby doesn't have any eye contact, night blindness, nyctalopia, nystagmus, hyperopia in general, and oculodigital sign. And with time, children often develop keratoconus. Now, the retinal appearance can be strictly normal, or it can look like RP since the beginning. And pathognomonic is a non-detectable and non-recordable ERG. There's usually no ocular malformation, and there is no extraocular abnormalities. Approximately 23 genes have been ascribed to Leber congenital amaurosis. This makes up about 70% of the cases. So there are 30% of cases of LCA in which we still do not know the genetic substrate. Notice that the CRB1 is a big major component here, RPE6 as well, and CEP290, and some other major genes. Retinitis pigmentosa should really be called rod cone dystrophy. The prevalence is 1 in 3,000 genes, 1 in 3,000 individuals, and it's a heterogeneous disorder that affects both the RPE and the photoreceptors. Now, it could be autosomal recessive, dominant, or X-linked. When you don't have a family history, it's often autosomal recessive, and in our population, it's mostly autosomal recessive. The age of onset is variable. The younger the onset, the worse the prognosis, and it's characterized by night blindness, progressive visual field constriction to a tunnel field, but of course the progress is very variable. There is a classic triad, which is the presence of bone spicules, which is pigment migration into the retina from the RPE, with what we call a pallid optic disc, pallid, optic nerve head pallor, and attenuated vessels. However, not all cases have that. Now, the central visual acuity is usually preserved, although you may have a completely non-recordable, rod ERG, or even a rod cone ERG with time. As you can see here, this the recording could be flat or very attenuated. Now, with time, what happens is the rods degenerate and the visual acuity declines because the cones depend on the rods for survival. So the cones are also going to decline, and this is going to lead to complete blindness. Now, patients can develop cataracts and CME. And we need to be on the lookout for these because these are treatable, and so at least we can help the patients in that term. Now, the retinal appearance can be very variable with no pigmentation whatsoever or a lot of pigmentation. It can even vary from person to person with in the same family with the same gene mutation, and the amount of pigmentation has no bearing on how severe the disease is. In general, the OCT shows the atrophy of the retinal pigment epithelium and primarily the photoreceptors. You can see here it's very atrophic compared to the beautiful stratification of the normal retina up here. Now, 50% of the genes in RP have been discovered, but the accurate genetic counseling is going to depend on the identification of the causative mutation and the gene. But let's look at some phenotypes that could lead us to make an intelligent guess in the clinic. Let's look first at the ones that have LCA, just the ones that we see at during birth, not during birth, but immediately after birth. This enzyme here can cause a very severe type of Leber congenital amaurosis. Again, Leber congenital amaurosis is nystagmus, blindness, nyctalopia, and oculodigital sign. So a very severe form of LCA. But what's nice about this is that often children have, and adults as they grow older, they have a coloboma in the macula that is surrounded by hyperpigmentation. It's an excavated area in the macula here, which is pretty suggestive. CEP290 can give LCA by itself, or can give LCA within a bigger context of a ciliopathy and syndromic disease such as Joubert syndrome or Bardet-Biedl syndrome. What's peculiar about this is you often see very early on a hyper-autofluorescent ring, and very early on you do sometimes have a preserved fovea, okay? Now, the thing is with this mutation is that it can also cause deafness, and therefore not every case who has RP and deafness is automatically an Usher syndrome. A CEP290 is possible, and it's very important to think about CEP290 and do the genetic testing and do an MRI of the brain because they tend to have central nervous system signs, and a kidney echo to looking for the Joubert syndrome. How about these? And these are very interesting. The mutations that can give both early onset RP but also LCA. RPE65. It affects approximately 5 to 10% of patients with LCA. It can also give early onset RP and autosomal dominant RP. In general, the fundus does not have a lot of pigmentation, at least initially. And what happens is that the children, okay, they have severe night blindness, but when there is light, they can navigate, okay? The nystagmus is usually mild or none, and the visual acuity can be good because you have a preserved central macula early on. And this is important because this is one of the reasons that this mutation in RPE65 was chosen for genetic therapy, because they wanted to test genetic therapy on maculae that still had the potential for improvement. So children with RPE65 mutations are not completely blind during the day, okay? So you tend to have these drusen-like changes, and sometimes this develop into large chorioretinal atrophic patches. What is very, very suggestive is if you do an autofluorescence, there is no autofluorescence. Absolutely. Why is that? Because this is a gene that interferes with the retinoid cycle, with the visual cycle. There is no generation of L11 cis-retinal, and therefore no fluorophores in the RPE, and therefore no autofluorescence. So very suggestive. You can make that intelligent guess even before sending the patient to genetic testing. LRAT is another one. This causes a severe LCA, and then the peculiar thing is that children like to stare at light, okay, when they see light, and it can look very similar to RPE65. Oftentimes you have a preserved macula in the center and a little bit of, hyperpigmentation around the arcades, and unusual no autofluorescence. Again, same thing, something affecting the retinoid cycle with no generation of fluorophores, therefore completely no autofluorescence. Now, RDH12 is the opposite. It is a gene that affects the visual cycle, but at a different stage, okay? And what you have here, you can have, again, and often a delay before the onset of the problem, so not necessarily immediately after birth. People here can be myopic, and what characterizes this? Two very peculiar things: a heavy fishnet pigmentation and a yellowish macular lesion. This is very, very, very peculiar. If you do an OCT, you're going to see this macular excavation. And here's one case that I saw with Dr. Belbey 2 days ago. We made the diagnosis even before looking at the genetic results. This patient had this fishnet hyperpigmentation and had the yellowish colobomatous lesion at the fovea with the excavation and the OCT. Very, very suggestive. Not pathognomonic. Again, genetic overlap is possible, but it is something that to think of. This is from another book that shows you just the similarity between the two phenotypes. CRB1 is a very important gene, and it's very frequent here. It can cause LCA, it can cause early onset of retinal dystrophies and autosomal recessive RPs, but one of the things that CRB does, it affects vessels, okay? So it's very, very common to see a vascular component or features with this type of degeneration. The age can be variable, and it's generally a severe dystrophy with a significant visual handicap. When it starts early on after birth, you can have the macular atrophy. You have clumps instead of just bone spicules, and often you have these whitish spots. In childhood, you again have the pigment clumping, and very often you have a preserved para-arteriolar or paravascular RPE. In adolescence, it can look like a one of classic garden variety RP, but when you have the ones that are where the pigmentation really follows the vessels, start thinking a CRB1. Again, also start thinking CRB1 when you have patients that have exudation and coats-like features. We know that RP have coats-like features, and it's often due to a CRB1 mutation. So the phenotypic particularity with CRB1 mutations is the fact that they have nummular pigment, coarse nummular pigment, and an unlaminated, very thickened retina. And they can have, of course, some exudation here or staining on the fluorescein angiogram. This is what I showed you earlier. This is one of our patients with a proven mutation in the CRB1 gene. Notice how the preservation next to the vessels, on either side of the vessels, and notice the thickened OCT. SPATA7 is a gene involved in ciliary transport that in which also you have, like CEP290, you have an hyper-autofluorescent ring, and often preservation of the central of the fovea, but the children here do not like the light at all, and they can also have hearing loss. So again, this is something where you should not think immediately Usher. It could be something besides Usher. And TULP1 mutations in general are associated with myopia instead of hyperopia, and often the foveal reflex is a little bit dull. Now, on the other side of the spectrum, you can have cone dystrophy. Cone dystrophy, where you have a cone impairment, okay, and it's much more rare than rod impairment. The onset usually happens anytime between the first 3 decades of life, and you have a progressive decline in color vision, in acuity, and worsening central scotoma. And in general, patients are legally blind by the age of 40. Now, you can have early on a very normal-looking fundus, or you can have what looks like a bullseye. And what makes the diagnosis at that stage is an ERG. You do an ERG, and you notice instead of having the flicker, you have basically a non-recordable flicker cone response or a single Hertz response. Again, a non-recordable response here. If you do an autofluorescence, you may find a lot of hypoautofluorescence here. Now, in pure cone dystrophies, the rods will stay normal. Patients don't develop night blindness, but they are severely handicapped with very poor visual acuity. But more often than not, a cone dystrophy goes into becoming a cone rod dystrophy. And this is a very heterogeneous group of patients. They will start to have progressive night blindness in addition to their central blindness, and progressive field constriction. And of course, you can have macular atrophy and features of RP. Patients will have both central scotoma and peripheral thinning of constriction of the field. They have generally a very thin photoreceptor layer, and of course the hyperautofluorescent ring demarcates the central part, which is usually where the perimetry and the sensitivity is very, very down compared to the outside where the sensitivity is a little bit better. And on an ERG, in the early stages, it will have a primarily cone dysfunction. Later on, you start to have more and more rod dysfunction. And of course, at any late stage of any of these diseases, when you have a flat or a non-recordable ERG, you really can't tell based on an ERG whether it started with as a cone dystrophy or a cone rod or a rod cone dystrophy. So the history here is very important. There are about 23 known genes that cause cone dystrophies, and some of them cause other things than other phenotypes than cone dystrophies. For instance, ABCA4 can cause Stargardt. CRX can cause, bona fide RP. Peripheral genes can cause, macular dystrophies, and so on. So you cannot really predict the genotype based on the phenotype, and vice versa, and therefore you will need a genetic testing. However, there are some pathognomonic cases in which an ERG can help. One of them is the cone dystrophy with the supernormal rod response. In these cases, the patients have reduced vision, they have hypoautofluorescence, they have a macular lesion, and when you do the ERG, you will notice that the flicker and the single Hertz when the photopic ERG are practically non-recordable, but the combined rod and cone response in scotopic conditions is really up the roof, really, really high. This is due to a mutation in the KCNV2. This is practically a pathognomonic ERG. Another one is when you have a mutation in the PL1, which can give a severe LCA. You also may have a macular atrophy here, but what characterizes this is a pathognomonic ERG with very slow rod responses. The cones will be very attenuated, but if you look at the combined response, this is normal. You have an A wave and a fast B wave. Excuse me. In this kind of mutation here, you basically have no A wave, and then you have a very, slow B wave. So this is very characteristic. Mutations due to CRX can give you anything, so I'm not going to go through this. Now, this is very, very often confused with retinitis pigmentosa, and we see a lot of it here in Saudi Arabia and in the Middle East in general. It's an autosomal condition. It's what we call the enhanced S-cone syndrome. It is due to mutation in the NR2E3 gene and sometimes the NRL gene, in which this gene controls the differentiation of photoreceptors into cones and rods. So basically, it tells the primary photoreceptors whether they should differentiate into rods and cones. And in this case, what it does is that basically the photoreceptors become all short wavelength cones, S cones, blue cones, okay? So what you have here is you have early onset of line blindness, and you have a slow progressive visual loss. Usually it progresses much, much slower than the other rod cone dystrophies, but it can be associated with central features, okay, such as schises and so forth. So what distinguishes this is this grainy retinal pigment epithelial disturbance that you see primarily around the arcade, and the fact that you've got these coarse clumps of pigmentation rather than bone spicules. You can, of course, have schises, such as in this case. This is a huge schises, as we can see here. The schises can be very tiny as well, and sometimes you have, different features of fibrosis. So subretinal fibrosis is a phenotypic feature, and it can occur in many, many forms. Again, this, if you don't recognize it, the ERG will be pathognomonic. What it shows you is a non-recordable rod response, and basically a photopic and a scotopic ERG that have the same waveform. They are similar, practically overlapping, okay, and the flicker ERG has a lower amplitude than the single hertz photopic ERG. So this is a pathognomonic ERG. Here are different features of this, and I present this because sometimes this, the classic feature that I showed you earlier here, where you have just the, the pigment clumping and the schises may not be completely evident. Sometimes you have other things that overwhelm the picture, such, for instance, various degrees of fibrosis, huge schises right here, okay, and this is another case of fibrosis. This is a schises, how it prevents on an OCT. But very importantly, okay, vitritis, or at least vitreous condensations that have been unfortunately mistaken for inflammations, and in which patients, unfortunately, I've seen patients that have had injections because they were thought to have inflammation and infections in the eye. So I've had patients who've had steroids injected and patients who've had antibiotics injected, unfortunately. Okay, so choroideremia. Choroideremia, when you look well enough, you know that you're not dealing with RP. Why is that? Is because you can see the choroidal vessels so clearly. There's so much atrophy of the choroid that even if you have pigmentation, okay, the atrophy is really overwhelming. And in general, the atrophy tends to be very peripheral, leaving the central island until the very, very end. This is an autosomal, an X-linked recessive condition that affects only males. So the transmission goes from the mother to the male, and it's caused by a mutation in the choroideremia gene. It causes night blindness and progressive loss of visual field. And generally, the patients, the males, are young, but practically blind by the age that they're 30, okay, or behaving like blind. Even if they have a good central visual acuity, their visual field is so constricted that they cannot function. So you have a centripetal progression of this choroid and RPE atrophy. And in general, in the Western literature, they will tell you that there is no migration of pigment, but in our population, actually, pigment migration is possible, okay, and it can be confused with X-linked RP. Another one that can be confused with choroideremia and RP is when you have gyrate atrophy. And here you have a lobular, if you look carefully, you're going to see that there is a lobular atrophy of the retinal pigment epithelium. You can see the choroidal patterns very, very clearly through here, okay? So, and again, the vessels may not be as attenuated, and the disc may not be as pale. So all these clues tell you that you're probably not dealing with RP, but rather with gyrate atrophy. It is due to deficiency in the enzyme ornithine aminotransferase, and it really must be recognized, because if you can alter the progression of disease by giving the patient low arginine diet, it was difficult actually, and with B6. Another one, very important, and we see a lot of it here, is the autosomal recessive BEST disease. Okay, it's due to a mutation in the BEST1 gene. Patients tend to have hyperopia. They don't have problems with night vision. They have decreased vision. They have RPE deposits that look like BEST lesions, like with egg yolk, but scattered all over the fundus, not necessarily in the center. More often than not, they're just around the arcades. They tend to have also RPE changes, particularly in the areas where these lipofuscin deposits have settled and the RPE has, atrophied. They often have a macular schisis, okay? And this is one of the reasons why this has been sometimes not recognized, not understood, and confused, again, with uveitis, where you see a little bit of fibrosis, you see these deep, they're not choroidal, they're actually between the RPE and the neurosensitive retina, but we see these yellowish lesions, and the fact that there is some fibrosis, and the fact that there is what something look like CME, you think, oh my God, this is uveitis, let me treat it as uveitis. It has happened. We've seen patients referred, treated as uveitis. Well, this was a classic pathognomonic picture of an autosomal recessive bestrophinopathy. We have a lot of these in KKESH, but they just need to be recognized. Autofluorescence really depicts these hyperautofluorescent spots very, very early on. And very clearly. Here are other examples. Same thing, fibrosis in the center with lipofuscin deposits, neurosensory retinal detachment filled with this yellow material that is super hyperautofluorescent here. Again, this is a little bit more discrete, yet still on the autofluorescent, you can see all the extension of the subretinal material. Finally, in a progressive retinal dysfunction, you have the juvenile retinoschisis, which is due to the mutation in the retinoschisin 1 gene. Again, this is also an X-linked recessive condition in which there is central visual loss, and what you have is a pathognomonic, cartwheel appearance, so it kind of looks like a CME appearance at the fovea, and a negative ERG. Very characteristic here. Basically, you have instead of having a normal high wave, a B wave, here basically you have a negative ERG, just an A wave. Very important to understand are the syndromic ones, because if you cannot do much about the eye condition, at least when you suspect that there is a syndromic retinal degeneration, that is when other specialties come into play, and you may be able to save the life of a person with that. So there are many, but I'm going to talk just very quickly about these 4 because we see a lot of them here. Usher syndrome is retinitis pigmentosa with a congenital hearing impairment. A lot of genes can give Usher syndrome, but the MYO7A is very prominent because it's essential, for hearing and for the RPE melanosome movements. Now there are 3 types of Ushers, and I don't expect you to know them all, but the type 1 is the most severe, which is combines congenital hearing loss, imbalance, and very early RP. The type 2 does not have imbalance, and the RP starts a little later. And the type 3 is a gradual hearing loss and a late onset RP and has the best prognosis. Bardet-Biedl syndrome, I'm sure you all know it. So it's usually evident since childhood. Many people, have these extra digits and are obese. You can practically tell when somebody has Bardet-Biedl just when they walk into the room. You think of it because of the obesity and the slowness, a little bit of slow, not mental retardation, but they're they have a slow mentation. This is an autosomal recessive condition and caused by, again, many genes, 14 BBS genes at least, including the CEP290. So this is a ciliopathy. So people can have extra fingers and toes, and they can have obesity, mental retardation, and key disease. Joubert syndrome caused by the CEP290. Okay, this is association of the retinitis pigmentosa, or the LCA, because it usually starts very early on, with what we call a molar tooth sign here at the midbrain. This is why it's important to do this, MRI, and they can have, ataxia, and they can have also renal failure. So it's important to recognize this. And finally, senior Loken syndrome, which is often associated with kidney dysfunction and kidney stones, and cystic kidney disease that can lead to renal failure. So it's important really when you see this fishnet pigmentation, okay, similar a little bit to the RDH12, except that they don't usually have the macular excavation. So it's important to think about that and do the genetic testing. And if you have this mutation in this gene, the NPHP5, then think about senior Loken and do a renal function test. Okay, finally, we have to differentiate the progressive and bad, generalized retinal dystrophies from the ones that are, perhaps a little bit more tolerated because they're stationary. They don't progress with time. And the 3 most important ones are the congenital achromatopsia, fundus albipunctatus, and the congenital stationary night blindness. Achromatopsia is also autosomal recessive, and it's a congenital cone disorder. And it basically, it affects, it's usually due to genes that affect the phototransduction cascade. Usually patients have low vision and are severely photophobic. They prefer actually to sit in dim lit rooms. They do have nystagmus, severe color vision defects. The fundus can be strictly normal looking. Sometimes if you can sometimes see a dull foveal reflex, but the fovea can really look very normal. If you do an ERG, the cone ERG is flat, the rod ERG is normal. And if you do an OCT, more often than not, you will see a little bit of this hyporeflective spot at the level of the photoreceptors at the fovea. This is being tested now. There are trials trying to reverse achromatopsia. Another one that can be confused with retinitis punctata albescens, which is a form of retinitis pigmentosa without pigment, is the fundus albipunctatus, which in general has these white spots, and they tend to have a linear configuration. As you go, the further you go out from the macula, the more they become linear, and they're very, very bright, peculiar, and very well demarcated white spots. People here have night blindness, okay, and this is the disease here is caused by a delayed rhodopsin regeneration. So this means that initially the rod ERG can be flat, okay, but if you put the patient long enough in a dark lit room, no, that doesn't make sense, in a darkened room, and you give the patient 5 or 6, 4 or 5 hours of dark adaptation, then sometimes what happens is the ERG becomes better. Okay, so this is a very pathognomonic sign, and the ERG here is diagnostic. Stationary night blindness, there are several forms of stationary night blindness. They have as the term indicates, it's a stationary condition in which people don't see well at night. It can be autosomal dominant, okay, and people here have normal visual acuity, but they have night blindness, and they stay like this for life. Or it can be autosomal recessive and X-linked, which appear much earlier, and they can even be associated with some nystagmus and reduced vision. In general, the fundus looks normal, but the ERG shows a severe dysfunction with a negative ERG, like X-linked retinoschisis, in which you have an A wave and no B wave. Finally, one word before going into how do we treat these things is that the genetic heterogeneity is very, very common. Despite all what I've showed you and the fact that, I'm telling you that things are pathognomonic and very suggestive, yes, they are most of the time, but sometimes you see heterogeneity or, overlap. For instance, these are people from different families, but they have the same mutation in the NR2E3, and you can see the way their fibrosis looks is very, very different. Again, this is 3 patients with the same BEST1 mutation, and they have totally different features, although they have the same mutation. So heterogeneity is possible. Now, what is our role when we see inherited retinal degenerations? And certainly our role has changed in the past 10 years or so, and particularly in the past 5 years. First of all, we must do a diagnosis and screening, and now we can no longer afford to say, oh, you have a genetic disease, I'm sorry, not much can be done. You have to really do as much as possible to get to a genetic diagnosis and help the patient. So how does this work? Is you have to do a careful evaluation. You have to diagnose this as specifically as possible. Ask the symptoms. The history often tells you when the things start, how did it start? Did it start with night vision problems, nystagmus? Did it start with day vision problems? That helps. Family history also helps. Age of onset will help determine the disease severity, and the family history will help you establish the inheritance pattern. Now, ask also about past medical history. Do a fundus exam and do a physical exam as much as you can to identify if you have systemic associations. And tests for diagnosis and as follow-up are usually a visual field whenever possible, and OCT to at least determine the health of the photoreceptors in the macula, in the central macula, especially if you're considering gene therapy. You want to make sure that you're doing gene therapy in an area where there is revivable cells. And autofluorescence, because with time what happens is this hyperautofluorescent ring can constrict, telling you that there is progression of the RP, or the area of the hypoautofluorescence areas can actually enlarge, telling you that there is progressive degeneration. So this is a good way of following up. And of course, any ERG, sometimes it's non-recordable from the start, but if you have a recordable ERG, the fact that you're doing some ERGs every few years can help evaluate the prognosis. Examining family members is extremely important. Sometimes you have no clue what's going on, and then you bring in the mother, the siblings, and you say, aha, you have an aha moment, you see something that looks like something and you reach the diagnosis like this. So extremely important. And finally, genetic testing nowadays it is necessary to identify the causative gene. And it's extremely important nowadays since we are starting in the era of genetic therapy. The faster and the earlier you do the diagnosis, the earlier you can install treatment. You can, for instance, give vitamin A. If you know that you don't have an ABCA4 gene, then you can give vitamin A, thinking that you're not going to harm the patient. If, on the other hand, the patient has an ABCA4 gene mutation, you don't want to give ABCA4 because you're going to, basically load the patient with that. And this is a gene, as I mentioned you to earlier, it interferes with the visual cycle. So you're going to actually make things worse by giving vitamin A to those people. You can send the patients earlier for visual rehabilitation, start school rehab earlier, start mobility training earlier, and so on. So genetic testing, I'm not going to go through this. We've had many talks in the past few months about this. You can look for a single gene if you're pretty confident. Let's say I know that this patient has what looks like an enhanced outcome syndrome. I'm not going to ask for a full panel. I'm going to just make sure, does this patient have an NR2E3 mutation, yes or no? It's less costly. But if you don't know, you can go to a comprehensive panel. And in cases where you don't find, the geneticist doesn't find anything, then whole exome sequencing is needed. Patient and family counseling is extremely important because these people are very, very concerned about the fact that they can lose vision, okay, and about their offspring. It should be performed really preferably by somebody who knows, who's knowledgeable in the inherited retinal degenerations, and of course it will require a molecular diagnosis. You can't just give counseling based on you don't even know what the gene is. So you have to confirm the diagnosis, and then this will give you an idea of when should I follow up, how can what is the estimated recurrence rate in future offspring. You can also do tests for families, but I'm not going to go into this. So in general, particularly if you have a syndromic problem, then it is better to refer the patient to a geneticist. Now, support and dietary. There are some, technicians that can help counsel patients how to deal with narrowed fields, with how to deal with, what they can do to improve night vision, give glasses, that help navigate, particularly in bright light. You should be able to follow the patients at least, checking for cataracts, because that can help a patient. If the patient has a posterior subcapsular cataract in a very narrowed field, sometimes removal of the cataract can buy some time. Cystoid macular edema is sometimes treated with dorzolamide, and sometimes people improve. Glaucoma, some cases have a higher incidence of glaucoma. Patients with Best disease, they are at risk for glaucoma. Patients with NR2E3 are also at risk for glaucoma. So this is important to follow them up. And you have to recognize when diet can help. For instance, if it's a gyrate atrophy, you should be helping the patient. Okay, we should be helping the patient. Refsum syndrome, Stargardt disease, we know that we should not be giving vitamin A, and so forth. Now, of course, there are exciting treatments underway: gene replacement, stem cell, retinal prostheses, oral drugs, and gene editing. Gene therapy is really the promising future for retinal degenerations. And the aim here is to rescue retinal cells function and maximize the survival. When can we do gene therapy? When we know that this is a genetic condition, when we know that the gene, and when you have an early or mid-stage disease. So forget about gene therapy at this point for patients who have advanced disease. That's not going to help, okay? You want to revive cells that are rescuable, okay? But of course, it's going to require engineered vectors to deliver the genes to the specific cells, okay? And what is the aim? Either to replace a defective gene, or to knock down the expression of a defective gene, or to introduce a DNA element, okay, that controls the gene expression, or to correct a misdirected splicing, sometimes you want to deliver a suppressor, okay, or to deliver neurotrophic agents. Now, the most common vector that we use is the adeno-associated virus. This has a small cargo. That means it can only take genes that are of small size, and it really is very good at transfecting cells, and the immune responses that it creates are benign. Lentivirus are bigger ones. They can take bigger genes such as the ABCA4, but they can be immunogenic, okay? And this, the recombinant adenovirus, we don't usually use much. You can give gene therapy via an intravitreal injection, okay? We usually do it subretinally, but we can give it intravitreally. However, what would happen is that you give it intravitreally, and you hope that the viral particles are going to go all through the entire retina and infect the entire retina, which would be nice, okay? But they need to go through the retina, and this is not always possible with intravitreal injections, because they have to pass through the retina to reach the RPE and the photoreceptors. And basically, the problem with this is that this viral transduction can actually reach the brain through the optic nerve and cause more problems, and it can cause inflammation. So in most cases, we do not do an intravitreal injection. We give the gene therapy, gene replacement therapy subretinally. And what this does is it only, of course, via a parsplanal vitrectomy and very careful technique, but it only transfects and it only affects the cells that are going to be in the vicinity or that have received that fluid with the virus. Now, we know about the RPE 65 trial, where they used the gene replacement called Luxturna, which is the vortigine and Ipavrovec, in 20 patients and who had RPE 65. Remember, RPE 65 is a genetic disease where you have a delay before the macula gets and the cells in the macula become really affected. So they used the gene replacement therapy in those patients where there were viable cells in the macula, and out of the 20 patients that they had in the phase 3 trial, the 20 of them showed improved mobility in the dark. 7 only had improved visual acuity, so acuity not so much, okay. But when you tested their full field sensitivity with a special machine called FST, about 13 out of the 20 had improved sensitivity, and therefore this drug was approved. However, you need to know that the long-term effect is still unknown, and there are unexpected results and limitations with this treatment, so it's not all rose and glory. What we know from animal studies is that the transfection has not created a particularly normal visual cycle, okay? The retinoid cycle was not normal. It was actually slow. Some patients had a pseudofovea formation. That means they prefer to fixate in the treated area rather in the original anatomical fovea. And one thing that we realize with the RPE65 treatment, and also, and I'm going to tell you this in a moment, is that the gene therapy did not prevent the degeneration. Atrophy continued despite the gene therapy, so it may not be a permanent one-time treatment as some people think. So, it is good. We are hopeful. We're actually very excited, but there are some challenges that remain. We actually did a MERTK gene therapy a study here at our hospital with Dr. Ahmad Aboud and Dr. Nicola Ghazi, and I'm continuing to follow these patients. 6 patients with MERTK RP were treated. There were no safety concerns. We published the results of the 2-year data a few years ago. Out of the 6 patients, 2 initially gained vision. Unfortunately, by the time 2 years happened, those visual gains were gone. And if you look at the fundus autofluorescence, you'll notice that there is continued, this is patient number 6 here, he had continued to increase the area of atrophy. So unfortunately, at 5 years, and now we are at 6 years after this treatment did not stop degeneration or the macular atrophy. So what are the factors that affect success in gene therapy? You have to be very careful before deciding who to treat and how to treat, okay? The delivery method selection has to be very careful. You have to appropriately select which vector is best. Okay, the surgical delivery, okay, if you have trauma during selection, during a surgery or, a wrong volume or a wrong site or foveal trauma, then of course the results are not going to be good. So it has to be very, very carefully done. And very importantly, which is something that we are still trying to understand, is the appropriate time frame. Okay, we have to do the treatment before, degeneration has progressed to a point where we cannot rejuvenate the retina as well. So for instance, in cases where you have CRX mutations or mutations that cause a lot of the retinal degeneration, this is still not an option, okay? Now, there are many trials ongoing, as you can see: choroideremia, Stargardt disease, Usher syndrome, X-linked retinoschisis, achromatopsia, and so on. So this is really exciting. What are the challenges? Please remember this. This is important because when people talk to you about gene therapy, they think this is it, Actually, there are some challenges that remain. We have to work on improving the vector capacity. We have to work on strategies that increase the number of transduced cells. This is not about just treating a little patch of retina. We would like to, hopefully revive most of the retina. We don't know yet the optimal dosage, okay, for the gene therapy for many of these, okay? We don't know yet the appropriate time to inject the gene therapy because we don't have enough natural history studies to stage diseases very, very accurately, particularly with all the phenotypic variations that happen, okay? It would be nice to tailor the treatment to each patient's characteristic, and it would be nice and needed actually is to know what is the best way to evaluate the treatment outcome. Is it the maze through which people walk? Is it the FST? Is it visual? What kind of what are the measurement strategies to what are the equipment or the methods to best measure the success of treatment? We also don't know how to deal with patients long term, where this is a new thing. Okay, so we've been doing but the people who have been injecting the gene therapy have been doing it for a few years, maybe 10 maximum or 12 maximum. So we don't know the long term management, and we may need different vectors for different retinal diseases. We also don't know exactly what to do if there are safety concerns in the future, okay, or if there's a delayed inflammation from the persistent viral capsids in the eye. And also we need to work on decreasing the cost because the costs are horrendous. So what do we do when we don't have the possibility to do gene therapy? One way of treating advanced disease is doing stem cell therapy, RPE transplantation, and photoreceptor transplantation. Now, RPE transplantation, it aims at to repopulate the cells, the RPE cells that are lost or damaged, so that you can get, photoreceptor survival, okay? And the RPE cells can be delivered in suspension or in sheets. And the potential candidates are those retinal dystrophies in which there is significant retinal, cell loss and in maculopathies. And it has been tried in Stargardt, and this is really on the horizon. And the other thing is photoreceptor transplantation, okay? Which means, in other words, transplanting rods so that cones don't die, because most of the problem with the inherited retinal degeneration is that it's not so much the visual field constriction, is that with time there is visual acuity loss and patients become really blind. So what we don't know is that how many rods do we need to transplant to increase cone survival, and do we need to also transplant cones in late stages disease? So despite the great advantages, there are significant risks, is that the loss of remaining vision due to the surgical trauma, you can have inflammatory response, immune response with stem cell therapy, and you can also induce PVR. So again, there are lots of considerations with stem cell therapy. You have to have a good correlation, matching the treatment with the disease type. You have to have methods to increase the production of these cells that you're going to transplant. You need more animal studies. We have to also define the window of opportunity and finding the right dose and modulating the immune response. I'm not going to go through this, but oral cis retinol therapy has also been tried in some patients in mice, but also in patients who have CA due to RPE65 and LRAT, therefore the visual cycle. And there are some encouraging results, but the patients do tend to they improve, their night vision improves, their vision improves, but when you stop the treatment, actually they become worse. Or at least they go back to baseline, and their dark adaptation is not completely normal. However, this is on the horizon. Retinal prostheses, there are several ways to treat when you have nothing left, where you basically have an inner retina that is okay, but a completely destroyed outer retina. Therefore, you can insert a prosthesis onto the retina or subretinally that will carry the information to the brain. And finally, editing gene with the CRISPR-Cas technology is very, very exciting. You can edit genes that are too large for the standardized vectors, and so that you can, get bigger genes such as the Stargardt gene, for instance, into the eye. And also, what you can do is you get a patient's autologous cells, make them pluripotent cells. They have a problem because the person with an inherited retinal dystrophy has the gene mutation in all his or her cells. So if you get a skin cell, you make it into a photoreceptor, and then you can use this technology to alter the genes in that cell or in those cells, and then transplant those into the eye. So it is really exciting. And it's been tried in a point mutation with the CEP290 gene. It's been considered, good. The results are exciting, and now trials are ongoing. Now, so in summary, inherited retinal degenerations have long been considered completely incurable, but the early successes of gene therapy provide great promise and deservedly create optimism. There are many, many challenges remain. One of the challenges is how to deal with the progressive retinal degeneration, which so far we seem that the gene therapy does not work. But and a lot of work still needs to be done. We need to understand the pathogenetic mechanisms of these dystrophies. We have to provide access to genetic testing to individuals at a lower cost. It would be we need more natural history studies so that we can better phenotype and better understand what is the best window of opportunity to interfere. We have to also work on improving the outcome measures and testing and standardization. For sure, there's a light at the tunnel. We're very, very excited in the retina community. This is happening, and I thank you very much for bearing with me, even if I went a little over time. Thank you very much.
Thank you very much, Dr. Novelati, for a comprehensive lecture. Any questions? Maybe we have a few minutes for questions. Yes?
Thank you. Yes. Yeah, you're right. You work at the King Faisal Hospital, so you probably have more access to the data of the incidence of these genes. But we wrote a paper with Dr. Fawzan Al-Kraya. It was published like three years ago, where we had looked at the recessive degenerations, and we found that most of the recessive degenerations, most of the genes that we encounter here are also encountered elsewhere, and then unlikely to discover many, many more in there. And CEP290 was not in the high ones. The high ones was like CRB and ABCA4, and even MERTK was considered high. Although honestly, we only have, as far as I remember, we only had 6 patients of MERTK. But so CEP290 was on the kind of the middle, not very, very common, but definitely we see Joubert syndrome here. We have Dr. Arif Khan, I believe, has also, I believe he has published something on that as well. Yeah, so we do see it. No, I don't remember that, but we can look into this. No, I don't remember the genetic, each mutation exactly, no. Absolutely, absolutely. The environment for sure. The how the other genes of that patient interact with the specific gene mutation is definite. There's nature and nurture. So the environment for sure has something. But I must admit that if you look very carefully and you spend time at looking at pictures of patients who are from the same family, the first impression, they don't look alike. But when you look very carefully, there are features, So this is why I think, with you and with Dr. Schatz and with myself and people who are interested in this, since we have a big community of patients with inherited retinal degeneration, it's really like spend some time into really doing a genotype phenotype correlations, because I think that's going to end up showing things that we haven't seen. I remember my teacher, you always used to say, well, you only see what you look for and you only look for what you know. So if you start looking, you will see. Yeah, for sure. I think artificial intelligence might be maybe one day the yeah. Yeah, you will need I don't know, maybe 1 million people to have artificial intelligence help us with that. Yeah, but thank you for your comments.
Okay, any more questions, Dr. Suleiman?
We started
Well, thank you, Dr. Noelati, for
welcome.
the excellent lecture.
You're welcome.
So, as far as I remember, the Luxturna study and their methods, they had a crossover. If you fail the test, you are crossed over to the treatment group. So, I think this is something that if I was a patient, that I was told that you are going to be blind, and I will be enrolled in a study that potentially I'll get treatment, I'll try to fail the test so I can go to the group of treatment. I don't know if that was, I don't remember that they mentioned something in the study that the crossing over was not announced in the beginning. Then they crossed them over to the group of patients who were tested, and they were randomized to the non-treatment group. It was not mentioned in the paper, but just to
It's an
highlight
interesting thought. It's an interesting observation. I do not know the answer to that, but I think it's an interesting observation. Thank you. Yeah.
Okay, we're running late. So thank you, everybody. Thank you, Dr. Novilati.
Thank you.
Thanks.
Thank you very much, and Ramadan Mubarak. I guess this is the last Grand Rounds before Ramadan. Take care. Thanks, Patrick. Thank you. Thank you very much. I don't know how to get out of here. Where do I go? Escape? Here we go. There we go. They frightened me today because they said that, the Ahlan, thank you very much. Thank you for your comments. Thank you very much. Appreciate it. No problem. Salmi alayha. Thank you. They said today that the USB wasn't going to work. And they wanted me to send my lecture by Gmail. So, I was like, what are we going to do,
Yeah, hopefully it worked out.
Yeah, alhamdulillah. Yeah. Allah Afiq. Thank you. Thank you very much. Thank you very much. I appreciate it.
Great review.
It was a review. Yeah. So,
Over everything.
Almost. I mean, I didn't do Stargardts. I didn't do, macular dystrophies as much, Yeah. It's, we could go forever on the but I think it'll be too boring. It'll be too boring, I hope it wasn't boring.
No, it was excellent.
Yeah, I just thought, I'll insist on the phenotypes that, can evoke exactly diagnosis, yeah.
Very nice.
Sure.
More like patient, and we can use the recurrent.